chairpersons. We are running short of time, so we will move towards the next session directly. And the next session is on the newer targets to treat in IBD. And for this session, the chairpersons are Dr. Chalapati Rao, consultant in gastroenterology, KIMS ISKCON Hospital, Visakhapatnam, and Dr. Ravindra Goyal, consultant gastroenterology, IV Hospital, Chandigarh. Over to you, Chalapati sir.
Yeah, good evening, everybody. It's a nice program. I congratulate the PGI team, my professors, and Dr. Vishal. So I would like to introduce the next speaker, Dr. Sumit Bhatia. He's a consultant gastroenterologist at Medanta, New Delhi. He's going to talk on newer targets to treat in IBD. Over to you, Dr. Sumit.
Dr. Sumit, are you able to hear us?
I can not able to see my presentation though.
You are visible now.
Okay. Somehow not able to. Can you see my slides, please?
No.
Still.
Share screen option. Can the organizer share the screen on his behalf?
Actually, we have lost Dr. Sumit. He's not online.
Oh, okay.
Yeah, we can see your screen, sir.
Yeah, your screen is on, Dr. Sumit. You're not audible, Dr. Sumit.
Am I audible now?
Yeah, please go ahead.
Okay. At the outset, I would like to thank Dr. Vishal and the entire team PGI for giving me this opportunity to speak here in this esteemed conference. And today afternoon, I'll be talking about the new therapeutic targets while treating inflammatory bowel disease. The new therapeutic targets are, in fact, being derived from what we call as a STRIDE 2 consensus, which is nothing but an initiative by the International Organization for IBD. And it's an update on the various therapeutic goals for treat to target strategies in IBD. So what is treat to target? Just with a brief introduction. So treat to target term was first coined for the rheumatological disorders. So in 2010, rheumatoid arthritis patients were started by, the treatment was started with fixed targets. And soon the same thing was extrapolated to the IBD treatment. So it is nothing but defining a predefined treatment goal and applying tight control and therapeutic modifications of whatever treatment we are giving to reach that goal. That is what we call as treat to target. So when we try to understand what does it mean while treating IBD, so we have to see that IBD is a chronic, relentless, progressive disease. So it has waxing and waning periods of inflammation. And we all know that even if the clinical symptoms are, clinical symptoms are not present, still the inflammation will be going on. And over a period of time, it will lead on to more bowel damage. And as the bowel damage keeps accumulating, the later half of the disease, the patients will have more complications like strictures, fistula, abscesses, and will end up with more disability. So the whole aim is that as soon as the diagnosis of IBD is made with specific interventions and defining specific targets, we intervene early in the course of the disease so as to prevent further bowel damage, which keeps accumulating over a course of time. In IBD, when we say that, what do we mean by treat to target? So how do we define targets and how do we treat them? So at the baseline assessment, we initially classify any given patient as having a low or a high risk of progression of IBD. And then we define a target board for us. Now, how this target board? So these are the different targets in a target board which are defined for choosing the target. And I would like to make a note, everybody to make a note of this, that the clinical response or the clinical symptoms are the outermost or the most widest of the part of this target board. And as we go on moving towards the bullseye, the treatment starts getting more specific. So under no circumstances, just achieving a clinical response can be the target in today's era with so many treatment options which are available. And slowly and steadily, we have to incorporate the other treatment targets here as well. So the four major treatment targets which we commonly use are the clinical response, the biochemical response, the endoscopic remission, and the histologic remission. The molecular response is still in its nascent stage and not utilized clinically very frequently as of now. And this definition has been going on for some time, that the clinical response and endoscopic remission gives us what we call as a deep remission, and the patient's chances of developing complications over a period of times are significantly lower. Now, if we combine histological remission in addition to endoscopic remission, this is what most articles will call as what is called as a complete remission or a complete mucosal healing. Now, this is what this flowchart summarizes what exactly is a treat to target, that we choose a patient, we define the target board, we define the targets, and at predefined intervals, we go on reassessing the patients to see whether those targets are being achieved or not. If the targets are not being achieved, we have to remodify our therapeutic strategies so that we are able to achieve those targets with the ultimate aim to control inflammation, to avoid long-term bowel damage and subsequent disability. Now, how do we choose those targets? So traditionally, the targets have always been the clinical indices. In Crohn's, it was always Harvey-Bradshaw index or the CDAI, or in ulcerative colitis, it was the clinical Mayo scores. Now, we know by today's evidence that the clinical scores have been shown to be very poorly correlating with objective markers of inflammation, whether they are biomarkers or endoscopic healing. Just to give an example, in this study of 67 patients of Crohn's disease, when at specified shorter intervals, a colonoscopy was done and medical management was accordingly modified, the combined probability of a patient to be in a mucosal remission for a long time was significantly higher when only the clinical indices were used. Here comes the role of STRIDE consensus. So STRIDE consensus are nothing but an initiative by IBD, which is a group of experts, and they tried to select the therapeutic targets and came out with the STRIDE consensus. This was an international consensus to give appropriate evidence-based targets to us, which can be utilized in routine clinical practice rather than in clinical trials. So the first set of consensus statements came out in 2015. So briefly about STRIDE 1 consensus, which were the initial targets given to us in 2015 for Crohn's disease. The targets were subdivided into different subgroups: clinical, endoscopic, histologic, imaging, biomarkers, and patient-related outcomes. Out of these, the most important were the clinical and the endoscopic targets. And they talked about absence of ulceration, that means complete mucosal healing, and resolution of patient's symptoms. Very importantly, please notice in 2014-15, when these consensus came out, the biomarkers of CRP and fecal calprotectin were not considered a target. Similarly, for ulcerative colitis, it was the the Mayo score which has to become 0. Clinical and endoscopic targets were the most well-defined targets by this consensus. Now, over the past 6 years, a lot of new evidence have come. Our armamentarium to treat IBD has changed. New molecules have come in, new biologics have come in, and hence there was a need to revise these and up the STRIDE 1 consensus. And one of the most important and pivotal trials which came out in last 6 years was the CALM trial. which showed that patients with active Crohn's disease, when they were divided into two subgroups, in one of the groups, the clinical management group, the treatment was escalated based on only the clinical indices. And then there was a tight control group where the treatment was modified or escalated based on clinical indices in addition to the biomarkers of fecal calprotectin or CRP. And the results were very obvious in the tight control group, wherein the biomarkers were used in addition to clinical markers. The outcomes in terms of remission were much better as compared to the only clinical management group. So this necessitated an update, which came very recently in Gastroenterology Journal, the STRIDE 2, which updated the previous targets of STRIDE 1 consensus. So what are the updated therapeutic targets? So STRIDE 2 talks about 13 consensus statements, which were developed by IO-IBD expert panel by using a Delphi process and a systematic review of literature. Again, this aim to provide contemporary new evidence-based targets to us for treating IBD. It is again specifically focused to be used in clinical practice rather than clinical trials, but it covers treatment targets now for both adult and pediatric IBD patients. So what are the targets which are available to us now? Again, they are divided into 4 subgroups, and I'll be talking about them one by one. So we have clinical targets, we have endoscopic targets, biomarkers, and quality of life and disability. When we go to clinical indices, most of the experts in this group agreed that the most important target has to be the clinical indices, but it cannot be the only target which has to be looked into. So symptom relief in terms of a clinical response and clinical remission are both important, but we know that clinical symptoms will correlate poorly with mucosal inflammation, especially in Crohn's disease. But for the patient, the most important thing are the clinical indices, and the rest, everything, most of the patients are not bothered about. Again, when we talk about clinical indices, there has been a trend to switch over from physician-based outcomes to patient-related outcomes. So patient-related outcomes are now a mandatory regulatory requirement for any trial to talk about the outcomes of any particular therapy. So the most commonly and validated patient-related outcome in adult Crohn's disease is what we call as a PRO2. Now, PRO2 has only 2 components, that is sum of the weighted daily stool frequency and abdominal pain, and both the components have been derived from the age-old Crohn's disease activity index. And similarly, for an ulcerative colitis in adults, the PRO2 comprises of rectal bleeding and stool frequency. So starting off with the targets, so the clinical response is supposed to be an immediate short target, and the treatment strategy has to change if the patient does not show a clinical response to the onset of treatment. The onset of treatment, short or immediate, is defined by whatever therapy we are using and the average time it takes. So for a different therapy, different timeline is suggested. So clinical response in Crohn's is defined as a minimum 50% decrease in symptoms of abdominal pain and stool frequency as per the patient, and in children, a decrease of the pediatric Crohn's disease activity index by at least 12.5 points, or a weighted index by at least 17.5 points. Similarly, in ulcerative colitis, a 50% decrease in the symptoms of rectal bleeding and stool frequency is mandatory before we call it a clinical response. The next target, which has been defined as for the clinical remission. Now, clinical remission is supposed to be an intermediate treatment target. And again, we have to change the treatment if we are not able to achieve this treatment target. So clinical remission has been defined by extensive evidence review in adults for Crohn's disease as having a patient-related outcomes in the terms of symptoms of abdominal pain less than 1 and stool frequency less than or equal to 3 score. This corresponds to the Crohn's disease activity index of less than 150 value, or we can have a Harvey-Bradshaw index of less than 5. Similarly, in ulcerative colitis, a partial Mayo score less than 3, or the patient-related outcome to the PRO2 score of rectal bleeding of 0 or stool frequency of 0. But again, I would like to emphasize that clinical response or remission are insufficient targets to be used as in long term. The next target, which was not mentioned in the STRIDE 1, is in children. Restoration of normal growth is considered now to be a long-term treatment target. Now comes the most important component of STRIDE consensus or treat to target strategies, which is endoscopic healing. Now, treat to target endoscopic healing is associated with improved long-term outcomes and may reduce the risk of bowel damage and mucosal inflammation, as all of us know. Even in the presence of clinical remission, is associated with long-term disease-related complications, flares, or surgeries. Now, endoscopic healing is a long-term desired target. Please understand, in STRIDE 2 consensus, the targets are time-bound. So endoscopic healing cannot be a target which has to be achieved in short term. It has to be long-term as per the therapy which has been chosen. And endoscopic response, while it can be a short-term target. So how are the targets defined? Endoscopic response, wherein a simple endoscopy score for Crohn's disease, more than 50% decline. Endoscopic remission, a simple endoscopic score for Crohn's disease, value of less than 10. Similarly, for ulcerative colitis, endoscopic response is defined by a Mayo endoscopy subscore decrease of more than 1 point, or a ulcerative colitis endoscopic index of severity by more than 2 points decrease. Whereas we say a patient is in endoscopic remission when the Mayo endoscopic subscore is ideally 0 or a UCEIS score of less than equal to 1. To assess the endoscopic response, it can be achieved by sigmoidoscopy or colonoscopy. And when not feasible, alternatives in Crohn's disease can be capsule endoscopy or balloon endoscopy, especially for the proximal small bowel disease. Now, histologic remission is yet not a treatment target in either Crohn's disease or ulcerative colitis. This was similar in STRIDE 1. It has been kept as not a formal target in STRIDE 2 as well. But in ulcerative colitis, histological remission can be used as an adjunct to endoscopic remission to represent a deeper level of healing. Now, we all know that there is fair evidence to say that histological remission in ulcerative colitis corresponds to a deeper level of healing, but it remains a very high hurdle clinically to achieve, and number needed to treat this this target does not have clinical evidence yet to say that it is better than endoscopic healing or fecal calprotectin reduction. Similarly, transmural healing as assessed by CT enterography, MR enterography, or a bowel ultrasound is yet not a treatment target in either Crohn's disease or ulcerative colitis. Now, in Crohn's disease, again, it has been advised to be used as an adjunct to endoscopic remission. Now, we all know that in Crohn's disease, as it is a transmural disease, cross-sectional imaging allows frequent assessments for us because we cannot do colonoscopies very frequently. But the problem is the current therapies have limited ability to achieve a transmural remission in all the patients. And hence, the experts were prompted to keep this target still in as an adjunct and rather than a formal target in Crohn's. Now, coming to the most important change as compared to the previous targets which we were using, which is the use of biomarkers. So as per the STRIDE consensus now, the normalization of CRP to values to the tune of upper limit of normal and a reduction in fecal calprotectin to a predefined range is an intermediate target to be achieved in ulcerative colitis and Crohn's disease. And the treatment strategies have to change if these targets are not being achieved. These biomarkers were formally taken as a target in STRIDE 2 as opposed to STRIDE 1. Now, if we talk about both the biomarkers, fecal calprotectin and CRP are the two most widely used biomarkers in IBD. In Crohn's disease, a recent meta-analysis which analyzed 22 studies showed a pooled sensitivity rate of 82% and a specificity of 72%. And systematic review of all the evidence and the Delphi-like process during the STRIDE consensus found that a fecal calprotectin cutoff value of 150 micrograms did correlate well with the endoscopic healing, the range being from 100 to 250. In ulcerative colitis, using CRP, ESR, and fecal calprotectin can clearly predict endoscopic activity, although fecal calprotectin appears to be much more sensitive. High values of fecal calprotectin has been correlated well with clinical disease activity, endoscopic healing, and histological healing. And some studies have even suggested that fecal calprotectin can be useful in predicting a relapse in ulcerative colitis before clinical symptoms or even endoscopic lesions appear. Now, the most important target which has been introduced in STRIDE 2 is absence of disability and normalized health-related quality of life, which have been taken as long-term treatment targets. Now, IO-IBD group has voted very clearly to include restoration of quality of life and reduction in disability.
Dr. Sumit, please wind up. Thank you.
should be part of the standard therapies. Now there is a very strong implication to this. A given treatment which will impair a quality of life, even though if it achieves deep healing, has to be changed if the quality of life is not being achieved. So these are the parameters which are clinically difficult to use in clinical practice for the targets suggested in STRIDE 2 with an IBD questionnaire and disability index. So this I will skip. I think I have already covered this. So the treat to target algorithm is that the new target algorithm is that if there is active disease, we start therapy as per the risk. We go on for a symptomatic response, look for clinical remission and normalization of CRP. These two are the short-term targets. Go on for decrease in calprotectin levels to acceptable range and normal growth in children. These are the intermediate targets, and then go on and try to achieve endoscopic healing and normalized quality of life and absence of disability. Now, while transmural healing and histological healing in ulcerative colitis and Crohn's disease respectively are adjunct targets, they are yet not formally incorporated in these guidelines as such. These are the average time duration wherein we can expect a response, remission, and the achievement of targets. But this is again a rough estimate, not a scientifically evidence-proved data. This is as per the experts involved in formulating these guidelines. With this, I think I would like to thank Dr. Vishal Sharma again for inviting me and helping me out in preparation of this talk. Thank you so much for a patient listening.
Thank you, Dr. Sumit. Thank you for a lucid presentation. I think because of short of time, I would wind up this session and hand it over to the organizers for the continuation of next session.
Thank you, Chairperson.